It's a pleasure to be here today. I would like to basically tell you a bit of a story of how do we think we can set the path to conquer HIV and AIDS, first in British Columbia and in the rest of the world thereafter. I entitled the presentation Treatment as Prevention, and that gives away the story. What we're trying to do is expand the coverage that we currently have with antiretroviral therapy. I know that's a mouthful, but we'll get to that in a moment. To stop the spread of HIV. And I got right down into the matter in the next slide. What you see here is what was happening in North America. This is USA data regarding the AIDS epidemic, starting in the early 80s, as you see, and rising very quickly, very alarming rates by the mid-90s. We had no clue at that time how we could stop this strain. It was really out of control. Around 1992-93, we secured the opportunity to host the Vancouver conference in 1996. This was a turning point for the epidemic. A number of things fell into place. We didn't really know what the hell we were doing. This was actually all fortuitous, and it just happened to us as we were doing the best we could to contain the epidemic. Notice that Joe Average developed for us, this is his signature here, in 1994, this iconic image, which we entitled One World, One Hope. And as I often tell people, we knew there was a one world affected by epidemic. We didn't know there was a hope in 1994. Little did we know that the hope actually was brewing in our own clinics here in Vancouver. And to our surprise, at the time of the conference, we were able to unveil new data that for the first time showed that by using triple therapy cocktails, in other words, 3 drugs all at once in people who were starting treatment, we could stop the ability of the HIV, the human immunodeficiency virus, to replicate. In other words, we shut down the replication of the virus. The so-called cocktail was eventually named HAART, Highly Active Antiretroviral Therapy, HAART, and HAART became the standard of care in 1996 at the Vancouver conference. And look at what happened then. We basically transformed this from a rapidly lethal disease in the early 90s into a chronic manageable condition. Death rate for AIDS in British Columbia dropped dramatically within a couple of years of us implementing this new treatment modality. Life expectancy, as shown here, has grown steadily, and in fact, it continues to grow. So we turned this around into a chronic manageable condition. And that was not the end. We also saw, and this again is the virtue of having a program that allows us to monitor what's happening in the community. We saw for the first time something that we never seen before. New cases of HIV dropped dramatically following the implementation of our HAART program in Vancouver and British Columbia. And you see here, there was nearly a 50% decrease in new diagnoses as we were expanding coverage with antiretroviral therapy. At that time, we didn't know what was going on, but we had a strong suspicion that this was driven by the effect of treatment among people who were infected with HIV. Some argued that maybe the Vancouver 1996 conference had an educational effect on the community, and therefore people may have changed their sexual behaviors, for example, and that could be at the root of this decrease in new cases. For that reason, I have plotted here for you the syphilis rates in Vancouver and British Columbia, and what you see here is that sexual behavior did not improve following the 1996 conference. Syphilis has been on the rise pretty much ever since. The other thing that we noticed, and again, it was a bit of a surprise, was that mother-to-child transmission among women infected with HIV had been steady until 1996 at a rate of about 30 to 50%. As you can see in this slide, the mothers are illustrated on a soft blue. The darker blue shows the children born to those mothers with HIV. Their rate was not going down really fast enough for our liking. However, after 1996, something dramatic happened. Mother-to-child transmission in the province of British Columbia basically stopped. Not only basically stopped, in the last year we have had this many cases of children born with HIV. We now know that by treating a woman infected with HIV, we totally transformed her illness. We transform it into a chronic manageable condition. We can tell this woman that she's going to be healthy and lead a near normal life, currently with a life expectancy of approximately 5 decades. So that basically puts her in a situation of leading almost a normal longevity. And in addition to that, that woman is now going to have a normal reproductive life. It's different now. It's truly different. We have changed this disease completely through the work that we've been able to do here and with colleagues around the world. So, what's the point of all of this? Well, I want to tell you that if we actually implement an aggressive program of treatment in our communities, we can actually see an AIDS-free generation around the corner. Why? Well, because already a number of years ago, we argued back in 2006 that if we use HAART to stop the replication of the virus, the amount of virus in the blood and plasma of people infected with HIV becomes undetectable. And when that happens, the same thing happens in sexual fluids. So if that is the case, it's easy to understand that a person infected with HIV will no longer be highly infectious. In fact, if appropriately treated and compliant and adherent with the treatment, that person becomes non-infectious. That's it. Can I leave now? Well, I'm glad you got it. So the point is, there is one more group that you need to be concerned about. Injection drug users, because injection drug users, say in the downtown east side or other places around the world, they are the drivers of the epidemic. So we want to be sure that treatment works in those individuals as well. And to show that in a definitive manner, we looked at our experience in the downtown east side. We had cohorts in the downtown east side that have been monitoring people with HIV and people without HIV to evaluate their outcomes and their determinants for the acquisition of HIV infection. So working with our colleagues in the center, we looked at the relationship between the amount of virus circulating in the downtown east side, in other words, the community viral load, the amount of the median value of virus that these people have in their blood, and illustrated here, you see that through our efforts, therapeutic efforts, we've been able to, using treatment, drive the amount of virus in the community to relatively low levels. This is actually a median viral load at an undetectable level. And so, in doing so, we argued that the number of HIV new infections in that community should also be going down. And voila, here you have it. On the red here, you see that high viral load in the community antecedes new seroconversions, new infections. However, as we drive the virus load in the community down, we also drive down the new infections. And in fact, this is so powerful that even in the presence of ongoing needle sharing with HIV-infected individuals who are on treatment and undetectable because of the treatment, HIV infection does not occur. So what this is telling us is that treatment is indeed a very powerful tool to stop HIV transmission. Now, in a study that was done in Baltimore, our findings have now been independently confirmed, giving us confidence that this is not a coincidental finding. And I'll read for you. In the Baltimore study, they found that from 1997, HIV incidence, or new cases per year, decreased by 74% for each 90% decline in the community viral load. A log decline is a 90% decline. In a separate model, HIV incidence decreased by 5% for each 1% increase in HAART coverage in that community. Imagine what a hell of an investment. Here you have a treatment that is life-saving, that renders the life of people infected with HIV basically near normal. And on top of that, for every 1% increase in coverage with treatment, you get a return on your investment of a 5% decrease on new infections. Treatment becomes not just cost-effective, but it's actually cost-saving. Now, the cherry on top became available earlier this year. Our colleagues in the USA, sponsored by the National Institute of Health, were conducting a randomized controlled trial, and again, another nice word, a randomized controlled trial where they were evaluating the efficacy of treatment in stopping HIV transmission in serodiscordant couples. Let me explain what that is. So what happens is this. Couples, sexually active couples, stable couples, through all over the world, predominantly in Africa and India, where one of the members of the couple, the man or the woman, was HIV positive and the other one was not, were invited to participate in the study. And in essence, randomly, they were assigned to take treatment either immediately or in a deferred fashion, while they were being monitored to see how much disease progression accrued while they were waiting to take treatment, or how many infections occurred in their sexual partners. To make a long story short, let me just get down to the definitive data. What they found was that as a result of the treatment, there was a 96% reduction in HIV transmission in these couples. In other words, there was only one transmission among people taking treatment. There were 27 transmissions among people not taking treatment. The study was planned to continue for another 5 years. The Data Safety Monitoring Board stopped the study and said, this is no longer ethical. We need to move on. We need to give treatment to all these couples. We cannot tolerate this difference to persist. This was a very dramatic new result. The one case where there was transmission occurring on treatment, it occurred on a couple where they were assigned to take the treatment, but the transmission occurred before the treatment could actually become effective in that couple. So in other words, what this is telling you is that in reality, if you give the treatment the opportunity to get on with its work, you will have zero transmission. There is no vaccine that can do that, and there will not be one in a long time. Now, in order to reassure you that we're not here to postulate that we're going to offer treatment to people just to stop transmission, the same study showed that there was a 41% decrease in morbidity and mortality, that is to say disease progression and death, among people who took the treatment early. So early treatment was life-saving, decreased disease progression, and dramatically reduced transmission. In addition, there was an 84% reduction on extrapulmonary tuberculosis. Tuberculosis is a very serious complication of HIV, particularly in the south of the world. So 84% reduction of tuberculosis in these patients. Dramatic results confirming that we should stop arguing about it and we just offer treatment to people in a facilitated way, because if we do that, we can stop the epidemic. Now, we in British Columbia have been privileged that with the support of the provincial government and knowing what we knew in 1996 to 2000, they allowed us to expand our treatment programs in a rather aggressive way. We're the only jurisdiction in the world that has done that, and I'm going to show you what we have been able to accrue as a result. I told you already that in the early days of antiretroviral therapy, between 1996 and 1999, we expanded the number of people on antiretroviral therapy very rapidly, and we had, as a result, a reciprocal decline in the number of new HIV diagnoses. Notice that when the number of people on treatment got stabilized based on the guidelines of the day, we also saw that the number of new infections were stabilized, suggesting that there is a link between both things. We went on in 2003 with the permission of the provincial government to expand antiretroviral therapy coverage. And look at what happened. Once again, as we expand the number of people on treatment, you see another significant decline in the number of people becoming newly infected with HIV. And more interesting yet, when we look at what happened in the injection drug community in this province, you see that nothing much was happening in terms of new infections, as the treatment was penetrating poorly in this community until in 2007, we implemented new measures to increase outreach on a facilitated way for these people. And as a result of that, we've seen a 50% decrease of new infections in injection drug uses all over the province. And that remains even today. And let me just assure you, this is not because sexual conducts have changed. The data in this panel shows you that syphilis, gonorrhea, other blood-borne diseases like hepatitis C, etc., they are all either stable or on the rise. So we cannot be proud yet that our behaviors have changed. What it has changed is transmission, because antiretroviral therapy, HAART, the cocktail, selectively blocks HIV transmission. And to reassure you that we're doing this with a benefit to the individual, AIDS cases, as you see here, are down in 2009 to the lowest level that we've seen since 1995, when the epidemic was just starting. So we're pushing back HIV to levels that we never dreamed it was possible. And mortality, as shown in this slide, is also going down. Death related to AIDS is going down, and we have every reason to believe that with this aggressive approach, we will reach a point where AIDS is not going to be anymore the significant problem that used to be in our province. And let me just reassure you that this is because we're doing something unique and different in British Columbia that is not being done around the world, and certainly not in the rest of Canada. These are the rates of HIV new diagnosis in British Columbia, starting in 1996 and going down until the year 2009. The 2010 number just became available, and it's further down here. So we have gone from approximately 850 cases per year here to down 301 cases in 2010. A dramatic benefit to the individuals, to society, to the public purse, to all of us. Notice that in the rest of the country, the levels remain stable. There has been absolutely no change, or more worrisome yet, as in the case of the prairies, driven by Saskatchewan, a 5-fold increase in the number of new cases. We need to spread this program to the rest of the country. And I'm here today to recruit you to help me to convince our political leadership, nationally and internationally, that we need to do this. We cannot tolerate that the HIV new cases are increasing by 5-fold in Saskatchewan, for example, where we are able to drive it by the same factor down in British Columbia. And to be honest with you, this is because of neglect, because the First Nations individuals in this country are not accessing treatment because, in my opinion, many people don't even care about it. So we need to change that. So where do we go from here? Well, actually, it's pretty simple. We need to test. We need to normalize HIV testing. And the #1 message that I want to leave you with today is that we need to have an HIV test, all of us. Why? Because if we normalize HIV testing, we're going to find those individuals that don't suspect that they're HIV infected, they are HIV infected, and because they don't know they're HIV infected, they cannot look after themselves, their loved ones, their partners, etc. Today, we have the opportunity to do this, and as you see here, we have a kit that we use in our clinics that allows us to do this in absolutely 1 minute. We get a poke, we get the test, and in 1 minute we tell you, you're fine, get on with your life. If not, we can help you. How do we help you? With treatment. What is a treatment? The cocktail. And the economists actually figured it out very early on. And they were saying, you know what, that guy, Julio Montaner in Vancouver, he has a good idea. If we use the antiretroviral therapies as shown here, we can get rid of AIDS, and in doing so, we can get rid of the epidemic. And the fact is, we're showing that we can do it, and what we need to do is find the cases, find the individuals, so that we can help them with the treatment, and in doing so, help to get rid of the epidemic. Now, am I crazy? No. Why? Because Clinton says so. Former President Clinton, already in August of 2008, he said, until there is a vaccine, we should do what British Columbia is doing. And he said it not once, but many times, and yet we cannot get our federal politicians to buy into it. We cannot get the leadership of the rest of the world to buy into it. We need your help. We need the people's anger to mobilize our politicians. Look, the United Nations program did a site visit with us during the Winter Olympics very recently, and I know John Furlan is in the audience. That was a great event. We had the privilege of hosting that event and convincing the United Nations program that, yes, this is the way to go. And when Michel Sidibe left Vancouver, he wrote a letter to the international partners to say, yes, we have to do it. And unfortunately, we're not quite doing it yet. The General Assembly of the United Nations actually endorsed this plan, and they said that by 2015, they are going to secure universal access to treatment, care, and prevention to all over the world. And guess what? They're lying. And Hillary Clinton actually, about a few days ago, November 8th, 2011, she said that they are going to increase the funding for PEPFAR, the Presidential Emergency Plan for African Relief, so that they can concentrate on the 3 things that they know it works. 1, male circumcision, which is not relevant to us. The next one, mother-to-child transmission treatment, which is what I described already. And finally, treatment as prevention, which is what I'm trying to convince you is the only way to stop the epidemic. Unfortunately, as of this week, the Global Fund, which is the mechanism that we have for globally supporting treatment rollout in the world, is bankrupt. And our own country is refusing to help. We have not stepped up to the plate to put the money that is needed to make these programs deliver as we promised. We promised at the UN meeting, now year after year, that we're going to do it. So we need your help, because if the Global Fund doesn't get the money, we don't get the treatment to Africa, Asia, Latin America, Russia, and the rest of the emerging European republics. We will have an epidemic that will be out of control. And the gains that we have seen to date will be wasted, and that's not acceptable. Thank you very much.